Sir, we are good to go.
Okay. Ma'am, shall we start with that? Enable the video.
Okay. A very good evening to all the people who joined for the program on infertility. And before we go to the main program, let's first invoke the blessings of the Almighty.
Either play the video.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
You're not.
Ma'am, unmute yourself.
Gayatri, unmute.
Oh, I'm so sorry. I welcome everybody for this webinar on infertility. And I now call upon the program head, Dr. Ramani Devi, to welcome everybody officially.
Good evening, everybody. It's a great pleasure and honor for us to have this webinar on behalf of Janani Institute of Fertility Training. So we have been conducting regularly, monthly webinars on any one of the interesting topics in infertility, so that everybody who attends the GIFT program will get benefited. Today, on behalf of GIFT, I welcome, and Janani, I welcome Dr. Chitra, who is the program head of this program, as well as the Dr. Ashika, who is going to do the case presentation. Today's topic is unexplained infertility. I think it is still around 10 to 15% of the women, they do suffer from unexplained infertility. As we are going to extend our investigations, maybe we can find a solution. But still, as on date, there are only limited things. And as per the guidelines also, certain advanced procedures are not recommended. So with this introduction, I request Dr. Chitra, who is a senior obstetrician, gynecologist, and infertility consultant from Lalita Nursing Home and Janani Fertility Center, to give a talk on this very, very important topic of unexplained infertility. Because it becomes very difficult for the consultant to say, counsel the patient saying that everything is normal, but if she doesn't have a positive pregnancy, then she will come and ask us why I did not conceive. We don't have an answer for that. Probably by doing an extensive studies, we can come to a conclusion. With this introduction, I request Dr. Chitra to go ahead with the talk.
Thank you, Dr. Ramani. Thank you very much for that introduction. Okay. We'll move on to the slideshow. Okay, moving on to the topic straight away. See, this unexplained infertility is actually, how will you define it? It is actually unprotected intercourse for about a year after having excluded the causes of infertility like anovulation, tubal block, poor semen parameters, and other causes of infertility must be excluded. Suppose you have done everything after 1 year of married life, and then you have found that there is no cause for infertility. Still, if you wait, probably 50% of these couple would become pregnant in the next 12 months, and another 12 will become pregnant in the 3rd year. But still, we have a handful of them who don't turn pregnant even after 3 years of waiting. So this is still a problem because, as Ramani said, there are about 25% of the couple who come to you with infertility remain unexplained. That means they don't have a specific cause, which would probably be the reason for their infertility. So we are, sitting with our fingers crossed, not able to explain why they have not turned pregnant. So that's the reason why we thought this is an interesting topic, or a topic which all of us should be attentive on. Okay. So when will you diagnose it? Because it's a diagnosis of exclusion, you have to make sure whether these patients have undergone all the pertinent evaluation for infertility. Are all the tests done and are they all complete? Whether they are all done properly, or have we interpreted all the results appropriately? So we should look into their history again and again, check all the reports, and make sure that there is really no cause for infertility that can be pinpointed. So what are all the basic investigations that we need to do for anybody, anything to be confirmed as there is no cause? So you have to have a semen analysis, you have to have a tubal patency test done, and you should document ovulation. For infertile women who come to you with regular cycle, you can go ahead and straight away do a follicular study without even any drug for ovulation induction. That indirectly confirms you whether this patient is anovulatory or ovulatory. So that gives you an idea what you should do the next cycle. So I prefer to do a cycle with no drugs at all to make sure that they are ovulating or non-ovulatory. So that all these tells you that there is no cause for infertility directly. Then suppose you still find no other reason. Sometimes you have to go for advanced tests like this, like a laparoscopy or a hysteroscopy. See, when will you ask for the laparoscopy? You think everything is normal, her cycles are regular, everything is okay. But still, there's this mild form of endometriosis where you can just see only a few powder burn appearance on the in the cavity in the abdomen, and then that could itself be the peritoneal cause for infertility. So you only until otherwise you do a laparoscopy, you will not be able to pick up this. So in such a situation, a laparoscopy may be warranted when you have waited for long and you have not found a reason for her infertility. When will you decide on a hysteroscopy? See, there is no Mullerian anomaly. There is nothing like that. But still, the endometrium is growing okay, but still it is not able to be, or you are not able to achieve a pregnancy with that being all right. Then you want to rule out other things. You want to do a biopsy of it. You want to find out if it is chronic endometritis. Then you have to go ahead and do a hysteroscopy and find out. Yes, if everything is all right, you think that she is ovulating, but still she's not becoming pregnant, you have to go ahead and do with ovulatory test, especially for women who are on the older age group. Then the sperm function test. See, semen analysis remains normal, but still there is no pregnancy. So you have to find out whether the sperm is capable of fertilizing. So at that point of time, you have to ask for sperm function test like DNA fragmentation index. Okay. So what are all these advanced investigation would tell? Probably it will rule out all these mild or possible reasons in male, like mild defect in the sperm parameters. Then there can be this acrosomal reaction or ability to bind to zona pellucida. All these things can still exist in spite of all your tests. So you have to be very clear to your patients about these things. And in women, what are all the probabilities? There can be abnormality at the level of cervix. So probably that's the reason why we offer IUI. And then there can be a defective oocyte quality, which you cannot prove until otherwise you go for an ART. This tubal motility. See, for that practical purpose, we do a HSG. We just find out that the tube is patent, but we do not know about the ciliary motility. That's one thing which is a big question mark They can remain there. They can all be totally bald. It may look patent, but for all practical purposes, they may not really be functionally okay. So this is another big area which we really do not know to explain with a report in your hand. A defect in the endometrial receptivity. That's what all these becomes advanced tests, and a subtle alteration in the follicle development and a luteal phase defect. Okay, this luteal phase defect, we should be thinking in our mind, even if they are ovulatory cycles. See, when a luteal phase, this we will all identify. When the luteal phase to do a progesterone assay for each and every one. So we can miss them. So when we think that they are ovulating but still not conceiving, probably it's worthwhile doing a progesterone test and finding out whether they have a luteal phase defect. Then there can be endometrial resistance to progesterone. So that's a little even higher test. So we will not do it routinely for everyone. Now, how do you handle? Because this luteal phase defect can occur in up to 7 to 8% of the patients in a normal ovulatory cycling patients. Okay, so what will you try to do? You have to rule out associated causes, which can be along with LPDs. So this can be a hypothalamic cause. It can be a simple hyperprolactinemia. So we would have not done the hormone test. So now at least if you try to do a hypothyroid, rule out hypothyroidism or hyperprolactinemia, and you correct it, they will become pregnant. So this can be at least done now and corrected. Okay. Now, is there a role for starting progesterone as such empirically to correct this LPD? This is a big question mark because there is no really a scientific proof to say yes, it will help. But then if we think it may, you can start, but then there is no scientific proof for it. Okay. Now, in these group of unexplained infertile patients, what are all the factors which you should keep in your mind to tell them what will be the success rate of them becoming pregnant when you start treating them or looking at them? Okay, when their infertility has been less than 2 years, they have not waited for the 3rd year, they have not reached you in the 4th year. They have come to you after 2 years itself. Yes, you still have a good chance of getting them pregnant at the earliest. Now again, the female age, when it is BFI, it is going to be difficult for us to treat. If it is between 30 and 35, you have to tell them the treatment has to be aggressive. And more so for Indian women. I'll tell you why in a short while. Okay. Now, with this age alone, I was telling 30 itself, it should ring a bell in your mind. Why? Because fecundity in women decreases after the age of 32 and very rapidly after the age of 37. So we should expedite treating or evaluating women who are beyond 35 and have come to you with history of infertility. So why this cutoff was taken or what made people think this way is because after going through a study, which it's a good French study, they have ruled out all the other causes of infertility. They have chosen only male infertility as a cause of infertility in this group of patients whom they have included in this study. Say they did 12 cycles of IUI with the donor sample and they have grouped them according to the age. So when women have been less than 31 years, pregnant rate has about 74%. But the same thing, when as age advances, see, there is a definite drop in the rate of pregnancy rate. And beyond 34, it has come down to nearly 50%. So they think that you should do the treatment at a younger age. Okay. Again, there was another study in which they have grouped patients according to their different age and then a study on IVF. They found that as age advances, definitely the live birth rates following even an IVF cycle declines. So all these things are very, very important. See, for women beyond 44 years, the result has been only 1%. So we should be alert and we should be able to counsel patients based on their age itself and push them into aggressive management at a younger age group. Okay, I was talking to you in an Indian women, should we really think that we should even push them into treatment at a younger age? Why? Because there has been a definite study by Manish Banker. He has compared Indian women with Caucasian women. Almost they had the same style. But then what happened is when he observed the ovarian reserve markers or the ovarian response that these two group of women had, he found Caucasian women responded better, but Indian women responded less. And the difference between this was like 6 years. That means an Indian woman at the age of 25 and Caucasian at the 35 were almost the same. So that means we are all banking on the studies which come from the West. So we cannot take 35 as our age or cutoff age. We should bring it down to 29. So that's why we were saying that we have to advance and think about all these things. And we should keep this study in our mind before we start counseling our patients when they reach you for infertility. And this has a, ethnic background has a definite impact on the success rate. So when it comes to unexplained infertility, now how do you manage? So for someone who's less than 30 years of age, this is all female age, and they have been married for less than 2 years. So, and with all normal ovarian reserves, then you can simply say, you wait for 6 to 12 months. Let's see whether you're getting pregnant. Because I told you, in the third year, about 12% of them become pregnant even. So about 60% of these who have been married for 2 or 3 years, less than 30 years, would probably turn pregnant. But only thing is, we do not know which 60 is going to become pregnant, and another 40 who was going to fall in that 40 group, or who is going to be in that 60 group, for us to tell that you may turn pregnant. That's the only fix that we have. But if we see women who are more than 35 years old and have been married for more than 2 years, then it is better we tell them, please take up some form of treatment for the other. So what treatment would you offer to them is, you either plan to increase the gamete quality or the gamete number, or you facilitate the gamete interaction. So what will you do by improving the gamete number? We all know this. For oocytes to be more in number, we know ovulation induction is the easiest thing that we have, because we have a lot of trump cards to really play with. This is like clomiphene citrate, aromatase inhibitors, gonadotropins, are all the ovulogens that we have been using from time immemorial. But in these unexplained infertile patients, just giving them alone is of no use. That's what it is not recommended, just using these drugs. Why? There are studies definitely which say, see, clomiphene with expectant management. That is, you give clomiphene and you have another arm of patients who are just waiting. As I told you, we have just told them wait for 6 months. And if you see the difference between the pregnancy rate, it is not at all statistically significant. Even with aromatase, it has not been very statistically significant. And letrozole and clomiphene also, if you give them, it does not show that letrozole has been wonderful and clomiphene has not been so. They are all the same, very average. Both of them, when you give clomiphene and try to make them pregnant, or if you allow them to be on their own, the pregnancy rate is almost this. See, when it comes to gonadotropins, does it show any improvement? No, when you just give gonadotropins alone, it does not increase the pregnancy rates again. But what it increases is the multiple pregnancy rates. So you have to be sure, for sure for yourself also, when you give gonadotropins, that means you have more number of follicles. So because of the more number of follicles, we are inviting trouble as multiple pregnancies. So we should keep this also very strongly in our mind when we start treating them with these drugs. So now what next, or what will then I do? I not just give tablets, or I will not give clomiphene alone. I will not give letrozole alone or gonadotropins alone and just do a follicle study. I will tell them it's better you go for IUI, because this is still considered as the first line of management for unexplained infertility. Can I do an intrauterine insemination when I document follicle, or when I say that they are ovulatory? No, in an unstimulated cycle, you cannot do an IUI. That is not recommended at all. Now, they have an RCT which included about 14,000 cycles with about 8,583 couples. See here, they have compared all. They have compared in a natural cycle. They have an arm with clomiphene and IUI. They have a letrozole IUI, gonadotropin IUI. Almost, see, in a natural cycle, it has been 6.2. It has not been very high with the gonadotropin cycle either. So they are not very fond of it, but still this is considered as the first line of treatment. But then when you just go and look into cycles with IUI, And then they have done this conventional dose of gonadotropins, like when you give about 150 HMG, or you just start with rec FSH and then do, or you give urinary FSH and then do, then you have a success rate of up to 35% in another study. But then watch out, multiple pregnancy rate has been 16%. So we have to be very careful. And this study compares with expectant management. So expectant management has been only about 9%, whereas pregnancy rate with gonadotropin has been as high as 35%. So after 33 cycles, when they noticed, they found there is no increase in rate at all. That means the success rate of the pregnancies is not increased after 3 cycles. It actually dropped. So they said after 3 cycles, it is not good to repeat IUI, because if you repeat it, it falls to 5.6. So don't waste cycle after cycle doing IUI. So 3 cycles is all that is recommended. That's why now the mode of treatment for unexplained infertility has changed. So they are saying you give expectant management. You don't want expectant management, jump to IUI. An IUI of only 3 cycles. Then you have to shift them for ART. That is what is recommended. And is there a difference between this 2 sitting IUI and a single sitting IUI? No, it's almost the same. Single is all that is recommended at 36 hours after the HCG is all that is recommended. Okay, now I was going on talking about shifting to ART. Can you just straight away as a treatment of choice for all these patients who are with you? No, not for all. Okay, but though we say that this is the best, or we think we have answers for many of them or not there. Yes, you can offer it only for some of them and not for all of them. Unexplained infertility in women who are less than 38 years, you have to give them expectant management for 3 months. Then you should do an ovulation induction for 3 months. Then IVF. Otherwise, those who are beyond 38 years, you can shift them straight to IVF, because results have been definitely better with IVF than with expectant management. I will support all with evidence in the following 2-3 slides. Okay. See, this is one common trial that we all know of. This is FAST trial. See, they have 2 arms where they have chosen and given these 2 pattern of treatment. In one group, they did 3 cycles of clomiphene and IUI. They had another group who had FSH. Then after the clomiphene cycle, they went for FSH and IUI for 3 cycles. Then they went for IVF. Okay. In another group, they did only 3 cycles of IUI. Maybe sometimes clomiphene, maybe sometimes it is gonadotropins. See, they found definitely there was an increased rate of pregnancy in the accelerated arm. That is 3 months of IUI and then straight IVF. They didn't give 3+3+, then did not go for IVF. And they found that the time interval for pregnancy also was shortened with the accelerated, obviously, because they get wasted only 3 cycles. When they looked into the pregnancy rate, notice that with clomiphene IUI, it has been 7.6%. Whereas FSH IUI, it has been 7.9. This is not statistically different. But then when you go for IVF, it jumped up to 30.7. So it's worthwhile jump straight for IVF in these patients at the earliest after 3 cycles. You don't have to waste money and time in another 3 more cycles. Okay, and this is another group of study where they picked up all the older couple. Here, the women were between 38 to 42 years, and they had about 154 couples. They were grouped into 3 groups, and one group had CC with IUI, one group had FSH IUI, another group had, IUI straight IVF. So when they found, see the difference. That was CC IUI was 21.6, FSH IUI was 17.3, whereas the pregnancy rate in an immediate IVF was nearing 50, that is 49%. So this is another choice, especially for women who are between 32 to 45. That's why I said after 38, no waiting at all. Straight going to ART would be a better choice. And when they look back into the live birth rates also, they found out live birth rate was as high as 84.2 when IVF grew. So what would you say for couples over 35 years with long duration of infertility? They are candidates directly for IVF, and because this shortens time to pregnancy and reduces the risk of multiple pregnancy as well. But then when there is failure rate with IVF, what do we do? That is the biggest question, because they found that there has been 8.4 to 22% fertilization failure itself in an IVF in those couples who had unexplained infertility. So should we go up for ICSI, or should we not skip this IVF and go straight for ICSI? No, that is not recommended. So we can wait, we can do an IVF. If we find that the failure rates are high, then we can go. Because fertilization rate with ICSI is definitely higher than IVF. And definitely the fertilization failure in ICSI has been lower compared to IVF. So we can definitely honk on ICSI, but still not take it as the bypassing fertilization, IVF. So ICSI for unexplained infertility, when they did a meta-analysis with 11 RCTs, they found that there is 30% higher fertilization in ICSI compared to conventional IVF. And fertilization failure was 8 times higher in IVF when you compare it with ICSI. But there were never live birth rates improvement. So that's why they did not recommend ICSI as a routine for all the unexplained infertility couple. Okay, now what to do even if ICSI fails? Because we have now in one condition, in one corner where we do not know what to offer for them. So we have to find out what is at failure, whether the gamete is at failure or the endometrium is at failure, now or the embryo is at failure. So now when you go and look into the gamete, we have to offer them only IVF, because this is the only condition where you are going to see the oocyte as well as the sperm cell. So IVF would be your first choice. When it comes to the male gamete, the sperm, see what I was telling you about the functioning capacity of the sperm. Fertilization potential definitely drops with sperm fragmentation index being high. So you have to go and ask for sperm fragmentation index. So there are many causes which increases the oxidative stress, and therefore it causes the DNA to fragment in the sperm. So if you can find any of these causes like varicose, if you have a systemic inflammation and genital infection which would cause this oxidative stress, an aged male partner, lifestyle which has been very bad, working all this night and awake during daytime is one big problem nowadays. And smoking, alcoholism, the environmental toxins in which they work, their pattern of work should be understood. That's why ionizing radiation, if you can pick up any of these, then you can ask for DNA fragmentation index. And how this will be tested is by various tests like tunnel, comet, SA or SAD. So any of these can be used and you can assay. Now, how will you interpret that? If the cutoff value, DNA fragmentation index should not be beyond 30. It should be below 30. 20 is what has been recommended, but we go up to 30. If it is up to 30, it's okay. If it is beyond 30, we don't want it. So we have to correct that with antioxidants, repeat it after 3 months. And then, just a minute. And then you have to proceed with ICSI. Okay, that's what I was telling. If the DNA fragmentation index is high, you can address the problem if you can identify the problem. Otherwise, go straight away for ICSI, because you will be avoiding all these things because you are picking up the sperm and injecting it into the oocyte yourself. So that will be a better option. Even if that fails, probably you can even choose a sperm from the testis directly, because that has the least DNA fragmentation cause. Okay. Now next, if it is the endometrium at fault, so you should have an endometrium like this. You should have a nice 3-line endometrium for you to do the transfer, and you should look for the color flow. If everything is good, then you do. Suppose you see all these things, but still there is no pregnancy. Then you have to find out about the quality of the endometrium. This is something you should know, something like window of implantation. So this is the time in which your embryo should go and sit on the endometrium. Only then it is going to go and sit and grow there. If you are away from the window of implantation, then your pregnancy may not occur. So how do you test for this window of implantation? That is the endometrial receptor assay test. This is just like a endometrial biopsy, what we would do for other reasons like histopathology. You can do it with the pimples. You can send that material and they will tell you whether it is in the receptive phase or a non-receptive phase. If it is a non-receptive phase, then they'll tell you whether it is pre the window of implantation or post window of implantation. So depending upon that result, then you can plan your next embryo transfer, and that is, specific for that patient. So that way you will improve the results. But always does this improve? We do not know, because we have to wait, and these tests are equally costly also. But then we have to choose and pick the patient and then do these tests and give them what is required. Another thing what is coming up now is about this eubiosis or the normal microbiota, like how we talk about the vaginal biota. There is something called as a normal microbiota even at the level of endometrium. So similar to the ERA test, you can do a the endometrial sampling. You can send it for test and find out how much is the lactobacilli and how much are the pathogens. So the lactobacilli should be about 90% for you to call it as eubiosis. If the bacteria are more and the lactobacilli quantity is less, then you have to treat the bacteria, you have to get rid of the infection and then build up the lactobacilli so that you make the endometrium more embryo friendly. So this can also be done, treated, and then outcomes have been good with some patients. We have tried. Pathogenic bacteria predominance means it is endometrial dysbiosis. This can cause implantation failure. So you can do this study and then treat them with antibiotics, and then you can give probiotics and improve the lactobacilli level, and it can improve the implantation rates. So how will you improve again the receptivity of the endometrium? There are many studies, many trials going on. They have tried giving colony stimulating factor, which will improve the endometrial growth. Therefore, it will improve the implantation rate. You can give it either subdermally or you can give it as a intrauterine insemination. Like how you do an IUI. You can just go do it as an infusion there. So that will influence the endometrial expression of the genes, which is very crucial for the implantation process. It will improve the endometrial vascularity. It will also change the local immune system there, and it will improve the cellular adhesion pathway so that it helps the implantation to occur. So another thing which is now being tried is the plasma PRP, platelet-rich plasma. So that also has shown some results. But all these things are only still under trial. So it is worth trying all these things when we don't have answers to these patients. So if at all one succeeds out of 10, we are still happy. So if not, we cannot claim that that is the reason. But then at least we have good results with anything that we do and try for them. Now, when it comes to embryo being at fault, we have to offer them PGT. This is all that we can offer. You have to take one blastomia, do the study and tell them whether this embryo is okay, and then transfer that embryo and bring about pregnancy. So when you suggest them pre-implantation genetic study, when there is a repeated implantation failure, when there is repeated pregnancy loss, when the maternal age or the paternal age is advanced, we do not know about their quality or about the aneuploidy that could occur there. So you want to test and then transfer the best embryo. So you can offer that. Severe male factor infertility, yes, you can go. When there is a family history of genetic disorder, you can go. Previous child with chromosomal abnormality, all these things are as usual, but this is not pertaining to unexplained infertility. So the first two are more with unexplained infertility. Okay, PGTA means it is for aneuploidy study. PGTM means it is for monogenic disorders, and PGTSR is for structural derangement. So you can, be more specific and asking what you want after you do the biopsy and send them for a IRA test and study. Okay. So recommendations given by AS Salem and Practice Committee of the SIRT in April 2017, a single euploid cleavage stage or a blastocyst should be transferred irrespective of age group. Be it 35, 40, 20, whatever be it, you should only transfer a single good embryo. That is what is being recommended. Okay. There are, of course, limitations even with PGT, but this is all that you can offer all of them to do well. Okay, all the guidelines, if I take ASRM, if I take ESHRE guidelines, if I take Cochrane review, if I take, NICE guidelines, everything recommends that you should push patients who are older straight to IVF, then keep them longer with ovulation induction. That is not at all recommended. Okay, doing just ovulation induction is, a sin from our side as a doctor for any unexplained infertility patients who are beyond 3 years of married life, not having any reason for infertility. Okay, then you have to give them, offer them IUI as their first line of choice. And the next is, give IUI only for 3 cycles. You cannot keep on doing again and again IUI for several cycles. So you should give only for 3 cycles, then shift them immediately for IVF. This is what all the guidelines says, and you should think in terms of that to treat properly an unexplained infertile couple. Thank you very much for the opportunity, and I hope I have covered the topic fully. Thank you.
Thank you very much, ma'am. You have covered the unexplained infertility topic extensively from basics to advanced tests. Thank you so much, ma'am. Now I call upon Dr. Yeshika, our own ICOG fellow in our Janani Fertility Center. She is from actually Pattukotai. She is a practicing gynecologist there. And at present, she is doing ICOG fellowship course at Janani Fertility Center. Now she is here to present a case on unexplained infertility, and our experts will discuss how to proceed with that case. Over to you, ma'am.
Thank you, ma'am, for the introduction. On the first note, I would like to thank Dr. Ramani madam and Dr. Chitra madam for giving me this opportunity. Now moving on to the case presentation. 28 years old, Mrs. X, wife of Mr. Y, who's 32 years old, coming from Trichy, who's a housewife, belonging to upper middle class status, married for 9 years, who's anxious to conceive, came for consultation. Menstrual history, she attained menarche at 13 years. Her LMP was 28th of August 2022. Menstrual cycles were regular, lasting for 3 to 5 days, 28 days cycle. Her flow was normal, no history of dysmenorrhea, premenstrual and intermenstrual bleeding. Marital history, married since 9 years, non-consanguineous marriage. Coital history, the couple were aware of the fertile period, coital frequency of 2 to 3 times per week, no history of dyspareunia, postcoital bleeding, contraceptive use, or any use of lubricants. She was a nulli gravida. Past history, no history of comorbids like diabetes, hypertension, thyroid, asthma, TB, cardiac disease, epilepsy, or blood transfusion. No history of previous surgeries. Personal history, she is of mixed diet, sleep and appetite were normal, bowel and bladder habits are normal, no addictions, no history of drug or food allergy. Family history, no history of infertility, premature menopause in the family, no history of tuberculosis in the family. Coming to the male history, he is an engineer by profession, not a known smoker or alcoholic, no history of any medical illness in childhood and adolescence until recently, no history of erectile dysfunction, ejaculatory disorders, no history of sexually transmitted diseases, genital trauma, mumps or measles, no history of past surgeries. Previous treatment history, patient started seeking treatment for infertility after 2 years of marriage. Patient was given oral ovulation induction with timed intercourse for 3 cycles. Details are not available. Patient had underwent her first IUI in 2017, which failed, the details of which are not available too. Patient did not take any further treatment and came here for consultation in 2022. Female partner examination. In general examination, she was moderately built and nourished. Her BMI was 23 kilograms per meter square. Vital stable, no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. No signs of hyperandrogenism. Bilateral breast examination was normal and thyroid examination was normal. Coming to the systemic examination, a cardiovascular system and respiratory system within normal limits. Abdominal examination, abdomen was soft, non-tender, no palpable mass, no organomegaly. Gynec examination, external genitalia normal, hymen not intact, pubic hair normal, no local lesions. Speculum examination, cervix and vagina healthy, no discharge. Bimanual pelvic examination, uterus was normal in size, anteverted, mobile, non-tender, bilateral cornices were free, no cornicial tenderness. Female partner investigation showed complete hemogram within normal limits. Random blood sugar, TSH was normal. Her AMH was 2.10 nanogram per ml and serum prolactin was 16.8 nanogram per ml. Histosalpingogram showed bilateral patent tubes with a normal cavity. Ultrasound imaging on day 2 of cycle showed a normal uterus of normal size with endometrial thickness 4 millimeters. Myometrial echoes were normal. Right and left ovary were normal, with both the ovaries having an antral follicular count of 10. Male partner examination, he was moderately built and nourished, BMI 24 kilograms per meter square, no pallor, cyanosis, icterus, clubbing or lymphadenopathy. His vitals were stable, thyroid was normal, facial and body hair growth was normal. Male partner investigations, blood investigations were within normal limits. Moving on to the semen analysis, he had a normal volume of 3 ml, total sperm count of 53 million, total motility 67%, morphology of 5%, and an impression of normozoospermia was given according to WHO criteria of 2021. So case summary, 28 years, Mrs. X, married for 9 years, with regular menstrual cycles, normal uterus, patent tubes, with normal semen analysis, with 3 cycles of ovulation induction with timed intercourse failure, and 1 ovulation induction with IUI failure, has come for further management. Provisional diagnosis, primary infertility, which is unexplained infertility. So the plan of treatment, considering the married life of 9 years and the previous treatment that the couple has taken, and also the stress and anxiety that they were undergoing, they were explained regarding unexplained infertility and counseled for IUI with husband's sperm for 2 more cycles. And the patient was also informed priorly that if that fails, they might need IVF. The couple wanted to proceed with IUI. So IUI for the second time was done on in September, wherein the patient was given ovulation induction with injection HMG 150 international units. The patient got 2 dominant follicles, and the post-wash sample was also good with 91 million per ml and motility of 99%. Insemination was also easy, but the results turned out to be negative. The third IUI was done in the month of November with the ovulation induction of letrozole and injection HMG. And there also the patient developed 2 dominant follicles, and the post-wash sample had 68 million and 99% motility. Insemination was also easy this time, but the results were negative. So the couple were then counseled and given options for IVF and ICSI. The couple opted to proceed further with ICSI. Hence, the patient was advised to review on day 2 of menstrual cycle for ovarian stimulation. So on day 2 of cycle, the right ovary had 6 AFC and left ovary with 8 antral follicular count. The patient was stimulated with injection recombinant FSH 100 international units and injection HMG 75 international units. On day 5 of stimulation, injection cerebrolix was started. And on day 10 of the stimulation, the patient was given a trigger with injection HCG 5000 international units and injection decapeptyl 0.2 milligram. Patient was posted for ovum pickup 35 hours after the trigger. The number of oocytes retrieved were 11. Total M2 oocytes were 8. Total fertilized were 8. The patient had totally 8 day 3 embryos, out of which 4 were of grade A and 4 grade B. So the patient was planned for frozen embryo transfer, and the stimulated cycle protocol was done. With the patient reviewed on day 2, the patient was given tablet letrozole 2.5 milligram, 2 HS for 5 days, following which on day 12, the endometrial thickness was optimal with 9.3 millimeters of thickness and good blood flow. And hence injection sustain 100 milligram IM was started for 3 days, following which a transfer was done with 3 good day 3 embryos. The patient was also given a proper optimal luteal phase support with micronized vaginal progesterone as well as oral dydrogesterone. The beta HCG unfortunately turned to be negative with less than 1 milli international units per ml. Then the patient was again called and planned for diagnostic hysteroscopy, which showed normal ectocervix, endocervical canal, uterine cavity, bilateral ostia visualized. Endometrial biopsy was taken and sent for HPE and TB-PCR. The report of TB-PCR turned out to be negative, and histopathological report showed proliferative endometrium. The patient was then advised to review on day 2 of next cycle for follow-up. The patient is yet to return for follow-up. Now, coming to the plan of further management, the first thing that we should do for the patient would be a proper psychosocial support, because addressing the anxiety and stress of the patient at this point would be very much needed, because the patient will be already anxious that what they thought as a last resort for treatment, ICSI, has failed now. So first thing would be giving a psychosocial support and counseling the patient that further investigations would help them to do a proper embryo transfer and giving a proper success in ART. So the further investigations would include DNA fragmentation index, a diagnostic laparoscopy, which can identify mild endometriosis and endometrial microbial assay to rule out chronic endometriosis, ERA testing, endometrial receptivity assay to know the window of implantation, and pre-implantation genetic testing may require. Thank you.
So,
Thank you, Dr.
Let-
Ishika.
yeah, let us come to the discussion.
Yes, ma'am.
Ishika, what
Yes,
are the, this case is obviously a case of unexplained infertility.
Yes,
See,
ma'am.
that is why long period of infertility, and she had repeat ovulation induction with IUI, not successful and gone for it. See, when you stimulated, you had the number of follicles to the oocyte ratio was not all right, isn't it?
Oh, yes, ma'am.
We had some 38 or 39 follicles, but how many follicles you had?
Ma'am, antral follicle count was 6 in the right ovary and 8 in the left ovary, ma'am. That's all we
Okay.
have.
So you got only 8. I thought
Initially,
that,
before starting IUI only, she had 10 antral follicle counts in both the ovaries. After both the IUI failure and by the time the patient was planned for ovarian stimulation for IVF, she had 6 follicles in the right ovary and 8 in the left ovary.
okay. So the total number, you got only 8 follicles.
Yes,
Okay.
ma'am.
So 8 follicles, out of that ICSI was done, and then you had only 3 good quality day
Yes,
3.
ma'am. Yes, ma'am.
Okay. Okay. So transferring the 3 good quality day 3, it did not, patient did not conceive. Was hysteroscopy done earlier to IVF? I mean FET, or after that?
And hysteroscopy was done after FET.
So but it was not showing any positive finding.
No finding.
Hysteroscopy was normal, and HPV was also normal. There is no evidence of chronic endometritis, because you
Okay.
said the future plan will be to go for rule out,
Microbial assay.
wanted to rule out to chronic endometriosis and uterine dysbiosis. Okay, so then did you supplement the patient with lactobacillus? Because we know that Dr. Chitra in her lecture has pointed out certain important salient points in unexplained infertility, starting one from DNA fragmentation. So in that case, I would like to know whether you want to do DNA fragmentation test for every patient who is planned for ART.
Ma'am, I don't think DNA fragmentation index is needed for all the patients, ma'am.
Yeah, so we will keep it as a reserve test only when in
Only
case
if
of
needed.
repeated ART failure, that it should be made very clear. Okay, then the second thing is evaluation of the unexplained infertility. You have rightly pointed out the diagnostic histolaparoscopy. Instead of going for a simple hysteroscopy alone, maybe a diagnostic laparoscopy you can pick up very early, mild to minimal to mild endometriosis, which can be treated by doing a cauterization or laserization or a peritonectomy, whatever it is. But the points, there is no dysmenorrhea, but still you can have asymptomatic endometriosis in these patients. So what is the advantage of doing laparoscopy in endometriosis? And what are the prerequisite? What will you give? What are the drugs will you give prior to FET? Maybe you can pick up the eggs, you can freeze it.
We can go for GnRH agonist like injection loop, right? And we can go for aromatase inhibitors like tablet letrozole.
See, but here it is a very early lesion. Letrozole doesn't come under the treatment of very minimal endometriosis. Okay, GnRH. So how does GnRH analogs helps in this situation if the patient has got early endometriosis?
By suppressing ovulation.
It is not by suppressing ovulation. It can modulate the NK cells. It can suppress the total. See, it is a hyperestrogenic status. So
Okay,
the endogenous hyperestrogenic status can be depressed, as well as it will prevent the progesterone resistance. See, the two important things you have is hyperestrogenism and progesterone resistant as far as the hormonal thing. You have sometimes you do get hyperprolactinemia also in these cases. That you have already ruled out. Then also it modulates all these prostaglandins will be suppressed. Cytokines will be suppressed. So all these things, GnRH analogs, when you give it for 2 to 3 doses, then when you do the transfer, maybe the endometrial pattern also improves very well. And the implantation rate is improved in these patients. Okay. Then after that, what will you do? Suppose if you're doing a laparoscopy, there is no evidence of endometriosis, hysteroscopy is normal. So then you said you want to go for uterine dysbiosis. Okay, now, but I feel uterine dysbiosis is not needed in this particular case because hysteroscopy shows no evidence of chronic endometritis. The evidence of what are all tell me some few important findings to say that in hysteroscopy to say that this particular patient has got chronic endometritis.
There may be hyperemic lesions,
Yes.
strawberry appearance,
and
stromal edema.
And sometimes you get micropolyps, which may not be picked up by the ultrasound examination.
Yes.
So all those things we can rule out. Okay. So then anything else? Then again, could you go for probably if you think day 5 transfer would have helped this patient?
Yes, ma'am. I think day 5 transfer would have been a better option.
Yeah, it is all grade A embryos.
Yes,
3 embryos were grade A. So probably you have the implantation, which is better with the blastocyst transfer.
Yes,
and if there is failure of blastocyst to form, that means whatever be that day 3 embryo is not going to get implantation. Okay. Then what are the situations in which you will go for PGTA?
If the patient age was high, like more than 35 years. And,
okay.
And if the patient has recurrent implantation
failure, even after transferring good blastocyst. Yes, so there is a definition for recurrent implantation failure. Okay. Yes, so if you are not transferring good blastocyst more than 4 in number, but the patient is not conceiving means, then you have to think in terms of RIF. And these patients can undergo PGTA if facilities are there. But again, there are certain fallacies. PGTA will not be always give the correct one because of the mosaic pattern. And then sometimes if you transfer, it can undergo autocorrection. So it is not all that patient, embryos which have aneuploidy will not be able to implant because it can possibility of autocorrection as well as mosaic pattern. So there are studies to say that even in mosaic pattern, the pregnancies are occurred. Okay, Anandi, then what? Pardon?
Ma'am, excuse me, ma'am.
Yeah.
Ma'am, regarding PGTA, ma'am, this patient is having the remaining embryos are only 6, ma'am. All are day 3, around 5 to 6, I think, ma'am. For PGTA to be done for a patient, we need almost 6 blastocysts, ma'am, minimum.
Yeah.
So then only we can, as you said, mosaicism and euploid status. If we need to get a minimum of 2 euploid embryo, you need to take biopsy of 6 blastocysts.
Okay, so that is there as from the embryologist point of view, you are telling. But will you go for the subsequent transfer? She has 6 more embryos.
Yes, ma'am.
But they are all grade A.
Transfer without PGT, ma'am.
Yes, that's what the next possibility is. You go for a blastocyst that we have discussed. Blastocyst transfer would have. Then what about the luteal support?
Patient was given micronized.
No. We routinely give this. Yes, micronized progesterone, NMP, low dose aspirin. But is heparin going to help you? Or GSG, this colony stimulating factor, that is going to help. See, these are all empirical things only. We can try with colony stimulating factor in the intrauterine injection, and then we can go for a transfer or a blast transfer, and then support it with heparin, and then there are so many things like HCQ, intralipids, everything. But I think none of them, they have definite role in luteal phase support except progesterones. So they were also telling estrogens also can be, routinely we do give estrogens also, because the idea of giving estrogen is to promote the progesterone receptor. That's all. What else? Anybody else? Anandi, do you want to have any more addition for this?
I think everything was discussed, ma'am. Audience, if
Okay.
they have doubts, they can post in the chat.
Audience, I think they have tech support. Do you find any questions in the chat box in the audience group?
No, ma'am. So
Dr. Chitra, I think she has done the discussion very well and almost completed. Unmute yourself, unmute.
I'm very sorry I couldn't join y'all.
Okay,
Akila
okay,
is not here, so I had to go for a delivery.
okay. So
Thank you.
it was a good discussion
Thank
with
you.
Dr.
Good, good.
Ashika, and confidently done. Congratulations.
Good, Ashika. Keep it up.
Thank you, ma'am.
Okay, now let us come to the end of the session. Any questions from the audience?
no, ma'am.
No. Okay.
We
Okay.
can conclude.
Conclude. Thank you. Thanks to all the participants. Gayatri.
Yes, ma'am.
Hmm.
It was a very elaborate discussion on unexplained infertility. And once upon a time, we used to think that that is an entity itself. But the more and more research, we get to know that the more and more people we are able to find reasons. Probably long ago, we used to say that almost 1/3 people were coming onto unexplained infertility. But the more and more research has thrown light into various features, we see that the percentage of people we would like to put in unexplained infertility is getting lower and lower. So it was a very elaborate and beautiful discussion. And I'm sure all the people who have attended this meeting are sure to be benefited from this session. Thank you very much for the presentation, Dr. Ashika, and the elaborate tutoring, madam. Thank you.
And thanks to the tech support given by MCure.
Thank you. Thank you for the tech support.
Madam, on behalf of MCure,
Thank
we
you.
thank all the faculties for enlightening the session. And this gives a lot of confidence for our marketing people to go with a rational promotional of brands, actually. Extremely thank you so much for the entire Tiruchi fraternity and Ramani Devi madam and Chitra madam and Yashika madam, Ananta Lakshmi madam and Gayatri madam. Thank you so much.
Welcome. Thank you.
Thank you.
Now leave.
Thank you, Computer Ji. So time is over. I hope everyone has answered it correctly. Options were 4 options, and most of them you can easily make it out. So Computer Ji will let us know exact answer. Maybe some correcting is there. So conjunctival mucosa is the correct answer out of these 4. And leptospirosis present as an acute febrile illness, and it may present as a jaundice. It may present as a fever. It may present even as a AKI or a kidney injury. And usually in rainy season, especially exposure to these rodents and all, someone is bathing or drinking during a, like in a village, there may be a pond exposed to a stagnant water. There they may develop a leptospirosis, and it may be fatal if not diagnosed early or not treated. So any exposed conjunctiva or any someone drinks, like, it's more of a mucosal exposure. So any ingestion of water which is contaminated can cause any exposure to ear or eye can cause this leptospirosis. Any of our jury members will like to add some more clinical findings?
Broken skin is also a
Yeah.
site of infection. Here it is intact skin is given, but yes, if it is broken,
Yeah,
then
if it is broken, so there may be some disparity, and we would have given full weightage to all the students.
yes.
But it is intact skin, so only broken skin. I think last quiz we had broken skin also, one of the options. So still, I think 30% C was the answer. 30% here, I think very few students were able to make it out. The conjunctiva can have, and these patients may have a conjunctivitis also because of leptospirosis. They may have a subconjunctival hemorrhage also in some of the patients, leptospirosis. So, Computer Ji, can we have the winner? Deepu Rajan. Okay, so from ESI Basai Darapur again, Deepu Rajan is the leading with 3 answers. Name is so common that I can remember that he's already answered 3 questions. So, Computer Ji, we'll go to the next question. We have already completed 6 questions. We have 20 questions still. Anybody can join, and 14 questions are still there to win. Question number 7 is Ponset disease refers to, is it polyarthritis in disseminated tuberculosis? Is it anterior uveitis in disseminated tuberculosis, posterior uveitis in disseminated tuberculosis, or meningitis in disseminated tuberculosis? Your time starts now. Ponset disease. One of the options is correct. Okay, so time is over. So if you read the 4 options, everyone has last word is tuberculosis. So I feel everyone, most of them have correctly answered, because tuberculosis is the question which is usually asked in all the even MBBS students. So here we have postgraduate student from the medicine. So Computer Ji will let us know what is Ponset disease, and it's polyarthritis in disseminated tuberculosis. So this is the correct answer. That means this arthritis is usually happens in patients who are having a tuberculosis, and this is more of a reactive tuberculosis. So patient has any tuberculosis, any part of the disease, and because of autoimmune reaction and reactivity, they may have a polyarthritis-like presentation. And treatment is you treat the tuberculosis, this arthritis also goes off. So other than that, anterior uveitis is commonly seen in patients like ankylosing spondylitis and other autoimmune disease, while posterior uveitis is common in tuberculosis also, but it's not called Ponset. Similarly, Ponset is only for arthritis only. I think some of the jury will like to add more comments on Ponset arthritis. It's important because
in Ghanshyam, we come across this Ponset disease in rheumatoid practice. More precisely, it extrapulmonary tuberculosis having inflammatory arthritis. Often people mistake as rheumatoid arthritis because sometimes rheumatoid factor will be falsely positive. But this is the erosion doesn't occur, only synovial inflammation is there. Constitutional features are out of proportion to the joint pains compared to rheumatoid arthritis, and deformity doesn't occur. And Montauk stress will be strongly positive, and TB quantifier will be positive. And if you do search clinically or imagology, we do come across tuberculosis focus in extrapulmonary region, sometimes lymph nodes, sometimes urogenital, sometimes even osteomyelitis, tuberculosis, multifocal osteomyelitis of tuberculosis, and any other organ. But usually lungs are spared, regions exactly we don't know.
Yes, a very important point. Sir has specifically said that RF factor is not rheumatoid arthritis. All RF patient positive are not rheumatoid arthritis. So like this patient, if RF is even positive in 10 to 15% of the patient in a low titer, even if there's a no rheumatoid disease. So like in this patient, if there's RF positivity, people may treat as a rheumatoid arthritis only. But here it's a reactive arthritis. So if you aspirate, CV0 will be negative. If CV0 is positive or ALP is positive in joint aspiration, that will be called a disseminated TB or a musculoskeletal TB. So that will be different. This is Ponset, this is reactive arthritis. So Computer Ji, majority have correctly answered 72%, and winner is again Deepu Rajan from ESI Hospital. Congratulations, Dr. Deepu, for another breakthrough answer within 5 seconds. So he's also not only answering correctly, he's answering fastest out of all the participants. So very, very wonderful performance by Dr. Deepu. And we can go ahead with next question. So this is question number 8. Which of the following anti-tubercular medication can cause hypothyroidism? Is it rifampicin? Is it ethionamide? C option is isoniazid, or D is streptomycin. Your time starts now. Tuberculosis, a lot of questions Computer G has given to the students. I feel majority of answer will be correct, and within maybe less than 4 seconds. So time is over. It was another question on tuberculosis, and Computer G will let us know, is it rifampicin or some other drug? Computer G. Oh, so it's not rifampicin, it's ethionamide. So answer is B. So ethionamide has been seen that it may cause hypothyroidism, and there's a similar sibling drug, prothionamide, which may also cause hypothyroidism, but not isoniazid or a streptomycin, which are the frontline drug. One more drug of anti-tubercular, I think PAS, para-aminosalicylic acid, which was used previously around 80s and 90s. It can also cause hypothyroidism, and because these drugs are to be given long term for months, so that should be checked. Computer Ji, we have not asked for the next question. Computer Ji, can we have any of the jury want to add any comments on this drug? Ethionamide, second line drug, or we can have the percentage distribution for answer.
Dr. Muruganathan sir has joined, sir. Good evening, sir. Welcome, sir.
Yeah, welcome, Manjula.
Good evening,
Very
Muruganathan,
nice.
sir.
I think good going. Good evening. I think very good going, and last day. So you're rocking. Good. And you know, para-aminosalicylic acid also can cause hypothyroidism.
Yes, sir. Pass. Yeah, exactly, sir.
So para-aminosalicylic acid can also cause hypothyroidism.
Exactly, sir. Correct, sir. You are correct, sir. So you are busy in your lecture or no hypertension. Still, you have correctly answered, sir.
Yeah, thank
full
you.
marks to you, sir. Great, sir.
Thank you.
You missed your lecture, sir.
See,
Thank you.
Ghanshyam, so much division on the audience because we don't commonly use the drug.
Yes, sir. We can see 30% students have
Narsimulu, in those days,
also.
PAs was the usual drug. Now they've changed. Yeah, that's right.
We are previously using for only multi-drug resistant tuberculosis.
Yes, sir. Ethionamide is second line drug. So can we have the winner for question number 8, sir? Computer Ji. Deepu Rajan. I don't know how he is answering fastest finger first. It's
Ranjan reading.
30. Deepu Rajan is done wonderful. Okay. So we have another question by Deepu Ranjan, and he's won the 8th question again. We can go ahead with the 9th question, Computer Ji. Which of the following most accurately describe hypothermia compared to fever?
Sir, this
Yes.
question we can pass. At least answer was shown already.
Yeah. Actually,
okay.
answer A was
Yes,
by
it was
by
already.
error.
Yes.
It was shown. Let us skip this and take the 21st question. Yeah.
Otherwise, we could have seen his fastest finger first. Who can? Who has the
You
finger
if you want, you can allow, but it was shown as A.
Okay. As per jury, we will skip this question because Computer Ji has already answered this question. It was first question, hypothermia, and we have already discussed last 2 days question on hypothermia, that it is different from hyperpyrexia because there is no thermostat setting, and your paracetamol and drugs doesn't affect there. So you need physical cooling and all. So we can go ahead with question number 10, Computer Ji. Okay. So jury will decide that we will have this quiz till 19th, or we will take one question from later on. Okay. So we'll go ahead with question number 10. And a patient who is chronic hepatitis B carrier delivers vaginally at 39 weeks of gestation. The baby should receive which of the following therapies on the first day of life? Is it hepatitis B immunoglobulin? B is hepatitis B vaccination. C is hepatitis B immunoglobulin and hepatitis B vaccination. D option is none of the above. Your time starts now. request Computer to keep the 20th question ready separately. If required, if jury decides, we can have 20th question. Otherwise, 19 questions are good enough for judging.
Yeah.
Not lone winner. So time is over. The question was the pregnant female who has just delivered her baby, and she was carrier hepatitis B surface antigen or a PCR positive for hepatitis B, and which should be the ideal treatment for her baby. You can have the answer, Computer Ji. Okay, so it's hepatitis B immunoglobulin should also be given, and hepatitis B vaccination is also required for this person or a baby, because HBIG will give the baby immediate protection. It is a passive protection from the hepatitis B virus, which may occur to this baby while delivering, while exposure to the amniotic fluid. While hepatitis B vaccination is already there in the vaccination of children, it is already there and should be given in institutional delivery, is given within 24 hours. So here, as soon as baby is delivered, hepatitis B vaccination should also be given. This is the correct option, and we can have some comments from the jury if they want to add. Hepatitis B, it's a very endemic disease in India, and a big headache for all the gastroenterologists and internal medicine people treating this chronic hepatitis B.
No, it is a common clinical practice, and it is quite easy question also. Passive active immunization. So yeah, correct.
But still it was tricky, and we have to see fastest numbers again.
Yeah.
So here we can see still 40% of the students fumbled with the answer. 60% majority are correct, and correct answer was combination of active and passive immunization for hepatitis B. Computer Ji, can we have the winner for question number 10?
Oh.
So again, Vipu Rajan. I'm not sure, Dr. Manjula, you have to see that other computers are working. They are able to click the answers, because I think even on midway, Vipu is already a winner. So majority of them, we have never seen this type of results for last 3 days.
Yes.
Okay, so I hope this.
No. As a jury, I would like to just give my comment. I think the quiz team, not the team, the organizational team who are in charge of this thing. Can you please check whether all other participants are connected, and are they pressing any issues or something like that? We'll take some 2 minutes or 3 minutes a break, and let this RX events and Dr. Manjula, Dr. Krishna Kumar, and in consultation with Ghanshyam Pante and Dr. Narsimlu and others, give a final decision on this issue.
I think we should give full credit to the person, because this was announced, I think, 1 or 2 months earlier only.
Yeah.
Timing is fixed, so we should continue with the quiz, sir. We may be the outstanding students, sir. We cannot say there's some issue. We should continue, sir.
No. I have no problem. Let others also say. Dr. Narsimlu and others. I'm not from internal medicine.
We are speaking to RX event. 1 minute you give us, sir.
Yeah. Not from NARZone, not from internal medicine. So it is only an issue of knowing whether others are connected and are they hearing correctly and all. So let the RX team events communicate to Dr. Krishna Kumar, Dr. Manjula, and others. I hope, sir, Professor Narsimlu, sir, is it okay with you?
Okay, sir.
Yeah. Please. Yeah.
What we can see, sir, we are here for last 4 days, sir. So average attendance was around 100 to 180, sir, in whole of the last 3 days. So if we can have how many numbers are there, we can see.
Yeah. Please. Yeah, that's what we want to know.
Dr. Manjula and Computer Ji can let us know how many.
Yes, sir. We are talking to them, sir. Give us a minute time.
Yeah.
Okay, we'll wait for some time. Yeah. In between, we can have some comments from Dr. Subbalakshmi also. Hepatitis B. She's a gastroenterologist from our place. So a lot of hepatitis B, chronic hepatitis B, she's taking care of them. So
Yes, sir, definitely we have to go with both the options, immunoglobulin as well as hepatitis B vaccination, because that is the way to prevent the child, the newborn, if the mother is already a carrier. And yes, sometimes if the baby is underweight, it is advised to take the vaccine at least after 1 month. We can give the time of 1 month, and then we can complete the dosage of the hepatitis vaccine, which is already in a schedule of newborn vaccination, as you already told, sir.
yeah, we call it. I think its name is Indradhanush. Although pediatrics we have left many years back, but new program. Thanks to the government, very colorful names and all.
Sir, colorful name along with that card is also very much colorful. So you can know that this name is Indradhanush only.
Yeah, so Indradhanush is the immunization program for pediatric patients, and Dr. Sudarshan sir is from preventive medicine only. So you must be very active involved in all these immunizations.
I told passive active immunization is the therapy. Yeah, immunotherapy. Yeah.
Yeah.
Madam, is it okay? Any report from?
Yeah. They're telling, sir. Dr. Krishna is speaking. 1 minute, sir.
Sir, I just checked with the.
Praveen. Yeah. Go ahead.
I just checked with the back end. It's just that the last question 6 of them have answered the right question, and the fastest is our doctor who has answered it. So we have the data to support that. Others too have answered, but the fastest is.
Okay. How many are there participants?
Yeah. Team RX, can you tell me the live?
Yeah. How many are participating in the quiz?
Yeah, someone can come, turn on the speaker, and then can answer.
Yeah.
Yes. What Praveen has told, I would like to second that.
Yeah.
For example, question number 4, we had 4 candidates giving the answers. Among them, Damini, Sahaj Singh, Dipuranjan were there. Dipuranjan was the fastest.
Okay.
Again, for the question number 5, there were 6 people. Damini, Neha, Divyanshu, Rahul, Syed, and Dipuranjan. Dipuranjan was the fastest. So we have the data, sir. It's
okay. So
coming through. It is fine as of now.
Yeah.
We have multiple participants. Among them, Dipuranjan is the fastest.
So there is a question from Mr. Praveen Singh. How many participants are now live with us? It is important to be.
Can someone answer this, please?
47, sir.
47. 47.
Yes.
So it is important not only to be fair, it is also important to be seen as fair.
Right, sir. We agree.
Thank you.
Thank you, sir. Thank you for that.
Thank you, sir. Thank you very much.
Computer Ji, can we have? Thank you, Computer Ji, for all the assessment. Computer Ji, can we have the next question? Okay, this is question number 11. Which of the following hepatitis B profile is consistent with acute hepatitis B infection? Is it HBs antigen negative, anti-HBs negative, anti-HB core antigen IgG positive, anti-HBe positive? B option, HBs antigen negative, anti-HBs positive, anti-HBc negative, anti-HBe negative. C option is HBs antigen positive, anti-HBs negative, anti-HBc IgM positive, and HBe antigen positive. And last option is HBs antigen positive, anti-HBs antigen positive, anti-HB core IgG positive, and HBe antigen positive. Your time starts now. Capital acute hepatitis B infection, not chronic. So one of them is correct answer. And again, hepatitis B. So time is over. So Computer Ji, it's a very complex. So many test reports are there. Some are negative, positive, slightly difficult. So I feel that will be difficult for students to answer. Computer Ji, can we still have the answer for this question number 11? So answer is C. Correct answer. HBs antigen positive, which may be positive in acute as well as chronic. Anti-HBs negative, which means antibodies against the surface antigen is usually negative because antigen is already positive. Anti-HBc, this is anti-HBc core antigen, which is IgM. positive. So this is IgM is acute. So this is the correct answer, which will give you a clue that anti-HBC IgM should be done for patient who has maybe a needle stick injury, who has a recent exposure, or also this is commonly done in blood bank to see that patient is not in a window period who is donating. Otherwise, it can transmit this blood-borne infection to the recipient. And HBe antigen is also positive in this patient. So HBC core antigen positivity will give you a clue that patient is having acute hepatitis B. And correctly, 80% of the students have correctly answered this question. And very awesome. I think very good knowledge of these North Indian students. And I think hepatitis B, Dr. Subha has already told, it is a big problem for our country. And India comes in intermediate zone. Around 2 to 4% of the population is having this hepatitis B infection in Indian population, which is moderate category or intermediate category. Can we have the answer? And any comment from the jury? Again, Deepurajan is the winner for, and he took just 2 seconds now. So he's getting better and better. From 6 seconds, he's come to 2 seconds now. Any of the jury want to add some points on hepatitis B again on prevalence and immunization? So we can go ahead with the next question.
Yeah.
Okay. So question number 12. The patient complained of palpitation and was brought to the emergency room. BP reading was 82/60. She was hooked to a cardiac monitor and with a reading of atrial fibrillation. So atrial fibrillation was seen there and fast ventricular response. So rate was also ventricular more than 100. What is the most appropriate initial management? Is it carotid massage? B option is amiodarone 150 milligrams slow IV bolus. Is it adenosine 6 milligram IV bolus or cardioversion by electric cardioversion? Your time starts now. Thank you, Computer Ji. So this was a clinical question where a female patient has come there in an emergency with palpitation and she is hypotensive. Her BP is 80/60, systolic BP is on the lower side. She is symptomatic with palpitation and her ECG suggests atrial fibrillation. Okay, and most appropriate answer, Computer Ji, can we have the answer? Okay, so it's a cardioversion by defibrillator because patient is hypotensive. So any patient who is hypotensive, symptomatic, and acute atrial fibrillation should be cardioverted. Although there will be some discussion, is it 200 joules or 100 joules or a biphasic or a monophasic current should be given. But nowadays, a lot of institute already has biphasic defibrillator, and they usually give 100 joules. But 200 is slightly more effective. Other than that, I think carotid massage is not effective. It's more often used in supraventricular tachycardia. Similarly, amiodarone could have been used if patient is not in hypertension or not in CHF, where amiodarone is given in 150 milligram IV bolus over 10 minutes infusion and followed by a 1 milligram per kg per ml per minute bolus is continued after that. Infusion continued for 6 hours. And adenosine is also only effective for supraventricular tachycardia or a PSVT. So this won't be the correct answer. So cardioversion defibrillator is the correct answer. Acute emergency medicine, most of the medicine resident must be seeing this AF patient, and 75% is correctly answered. Any of the jury will like to add any comments on cardioversion, AED use, AF? So this, I think, anyone want to add? Any patient who comes more than chronic AF or who has the symptoms for more than 2 days and all, they should not be acutely cardioverted. So they should be first anticoagulated as such, if possible. But patient in CHF and hypertension should be immediately cardioverted. You should not wait for, because there will be more mortality in that. And stable patient and patient with even amiodarone can be used in those patients who are stable and who are more than 48 hours duration of AF. 75% correct answer, and we can have the winner. Dr. Deepurajan again, and he's taking less and less time. I think he's taken just 3 seconds to answer this question. And we can go ahead with the next question. Question number 13. Anti-SRP antibodies may be found in, is it dermatomyositis, is it polymyositis, is it inclusion myositis, or D option is immune-mediated necrotizing myopathy? Your time starts now. Thank you, Computer. So time is over. The diseases which has been enumerated are inflammatory, idiopathic inflammatory myopathies, or IIM is there. So slightly difficult question and more of a related to rheumatology. And we can have answer from Computer Ji, and Dr. Nasimlu will like to add some comments, special comments. He's expert in these myopathies. So answer is immune-mediated necrotizing myopathy, which is a rare form of idiopathic inflammatory myopathies, and I think 4 to 8% is the percentage of myopathies seen in this condition. And the full form of SRP is signal recognizing particle, which is a ribonucleoprotein. So Dr. Nasimlu will like to add, or any of the jury?
It's a very good question, but difficult question for postgraduate medicine. The question is for DM rheumatology students. Is one of the cause of refractory myopathy, and often refracted to methotrexate, cyclophosphamide, most of the drugs, but the response is seen good with rituximab. So rituximab is a drug of choice in necrotic myopathy associated SRP antibodies.
Yes, sir. So a lot of necrosis is
for
seen.
muscle biopsy also.
So first steroid can be tried high dose and followed by CD.
Steroids must steroid.
Rituximab can be
What
used.
the steroid sparing drug. But I'm so happy so many people answered so rightly.
Yeah, so a lot of, I think rheumatology is more sort of a sub-specialization. So
New Harrison has given this, but Davidson not given this. So most of
this
the
is the postgraduate students, so they read Harrison only. The Davidson is for MBBS students. So 66% has correctly answered, and another of this SRP antigen is HMG-CoA reductase inhibitor. So that receptor is also included in this. There's necrosis of these receptors also. So can we have the winner for question number 13? Difficult question. Okay, so now we have Dr. Divyanshu. We have a different winner again, and he's from Sri Mahant Indres Hospital, Dehradun. So he's coming from Devbhumi. Good, Dr. Divyanshu. Congratulations. So can we have question number 14? Oh, sorry, 15 question we have reached. Which one of the following is incorrect in pathogenesis of leprosy? The lesion is Lucio phenomena have heavy parasitism with AFB and may be fatal. B is type 2 lepra reaction occur in lepromatous end of leprosy spectrum and present with erythema nodosum leprosum. Type 1 lepra reaction are downgrading reaction and seldom present with nerve trunk involvement. And fourth option was Mycobacterium lepra cannot be cultivated in artificial medium and tissue culture. This is the incorrect one you have to choose. Your time starts now. Time is over. Thank you, Computer Ji. So this was again with a negative stem question on leprosy, which is a problem in Indian state. And we can see here lepra reaction type 1, type 2. A lot of leprosy patients are treated with dermatology, but we do see a lot of patients who comes to our neurology OPD or internal medicine with mononeuropathy, or maybe thickened nerve, or maybe a mononeuritis multiplex also. So, Computer Ji, can we have the correct answer? Okay, so this is not correct. This is incorrect answer for leprosy. That means type 1 lepra reaction are downgrading reaction, which is correct, and but seldom present with nerve trunk involvement. So nerve trunk involvement is very hallmark of these reactions, both type 1 as well as type 2. That means they may present a sudden wrist drop. They may develop as a foot drop with sural nerve involvement. They may have an involvement of this ulnar nerve with the claw hand. So these one by one nerve involvement is classically said as a mononeuritis multiplex. So this is incorrect answer in the form of leprosy. This is commonly seen in lepra 1 reaction. Other than that, Lucio phenomena, this is severe form of leprosy where bacillary load is very high, not low, very high, which is the correct answer. And commonly seen in, I think, South America setting, but Indians in India also, they may present as a maculopapular rash with a severe mutilating disease. Type 2 lepra reaction, again, it is severe form of leprosy where the AFB load or leprosy is very high. They may present as the Edmund nodosum leprosum, which may be an emergency set in these patients. And we know that Mycobacterium leprae is not easy to cultivate, similar to AFB of a Mycobacterium tuberculosis. So correctly answered is not in majority. I think the correct answer was C answer. I think 1/3 of the students have correctly answered. And can we have any of the jury comments? I think leprosy is very important thing for PSM, as well as I said, even our rheumatologists or our internal medicine. It's very important, and it's very difficult sometimes to diagnose this thing. They come as rash, they may neuropathy, they may come as fever. Sir, any of comments from jury?
Yes, the presentation is very vague and atypical. So it is usually difficult because we think like neuropathy, if patient present to us with neuropathic symptoms, we think of some nerve involvement, but not leprosy as a first diagnosis. Though that should be this thing that we should think of this also, because it is very common in India, as you told, sir.
Yes, sir. So sometimes it's easy. Yeah.
It's
Dr. Sudarshan, sir.
It's equally important to palpate the thickened nerves, which we actually ask. So what I'm saying is that it's equally important to know how to palpate the thickened nerves for a postgraduate. So actually, whenever there is a CNS case, we ask them to palpate the nerves, and it's again a challenge for them. So it's just an addition to what you are saying, sir.
Yeah, so ulnar nerve examination is very important for these mononeuropathy and all. Sural nerve, ulnar nerve. So yeah, thickened nerve DD is one of the important questions in the examination of a neural case. So thank you, Dr. Ramesh, and we can have the results for question number 15.
Yeah.
Okay, so we have a new winner today, Dr. Shikha. She is from Mahatma Gandhi Medical College and Hospital, Jaipur. Welcome, Dr. Shikha, and congratulations. And she took just 4 seconds to answer that leprosy may have a nerve involvement, which is a common involvement. So we can go ahead with the question number 16 now. Okay, so question number 16, autoimmune thrombocytopenia is the adverse effect of which of the following antitubercular drug? Is it isoniazid? Is it rifampicin? Is it pyrazinamide? Is it ethambutol? Most common. Your time starts now. Most appropriate, most common. Thrombocytopenia. Computer G. So your time is over. The question was, I think all the 4 primary drugs are there, and the question was which drug causes most commonly thrombocytopenia. And Computer G will let us know which is the common, because we all are using all 4 ATT, and it's a rare phenomena, not very common. We don't do CBC before starting ATT as such currently. So rifampicin is the answer. Although literature suggests that thrombocytopenia may be seen in all 4. It can be seen with isoniazid, it can be seen with pyrazinamide, as well as ethambutol. But rifampicin is the most common of them, but still not very common. But out of those 4 things, most common, and it is autoimmune phenomena. So when you withdraw the rifampicin, the thrombocytopenia do recover, and if the culprit drug is identified, rifampicin should not be reintroduced, and should be, there is a headache that what is the next drug to be used. So second line drug, maybe a streptomycin should be added. So sometimes it's become very difficult to know that is it idiopathic ITP or is it drug causing rifampicin and all. But sometimes it may be very severe, requiring steroid, IVIG, or any immunomodulator in the form of IVIG and all. So any of the expert, most of them, tuberculosis is very commonly treated with everyone. Want to add anything on this? Will Computer Ji give us the results? Okay, so Computer Ji correctly said rifampicin has been identified by majority of the student, 50%, and any of the jury very actively involved. Thank you for joining us. Want to add anything about rifampicin causing autoimmune thrombocytopenia? Have they documented any of this thrombocytopenia during their medical clinics?
No. Well, rifamycin, when patient was on 82 3-drug or 4-drug regime, whenever thrombocytopenia comes, rifamycin was first we thought. Thank you, Dr. Ghanshyam, bringing this and educating the people who are participating is very important. The people not aware, they continue rifamycin and we buy the problem. So rifamycin is the most sensitive drugs causing autoimmune thrombocytopenia. We do come across once in a way.
Yes, sir. It's a rare thing, and even it's not even in percentage. Only case series or some case reports are there. But yeah, really documented and has been seen in clinical practice also by our colleagues also.
Yeah.
So we can have the winner for question number 16. Dipurajan again, and he's from ESI and he's from Delhi. That's a good thing. This is North Zone quiz, so I think all of the Jammu Kashmir, Himachal, Uttarakhand, Punjab, Haryana, Chandigarh, UP, Bihar, they all are involved in this North Zone. And the most commonly answered is from Delhi only. That's a good thing. That is a positive thing. So we can have a next question, Computer Ji. Question number 17. Which one of the following statement is true regarding pyomyositis? This is pyomyositis, not polymyositis. It is associated with systemic disorder like SLE, rheumatoid arthritis. Is it glucocorticoid are the drug of choice? Aspiration from the muscle may show gram-positive foci in pus, or a myositis antibody Jo1 is present, which is predictive of increased risk of lung inflammation. Your time starts now. As this quiz is fever quiz, a lot of questions are on fever, inflammation, and infection. So, and that's why a lot of inflammation is coming, and infection, antibiotics, antitubercular. So your time is over. This was the question number 17. And computers, you will let us know how to differentiate pyomyositis versus polymyositis. Computer, can we have the correct answer? So it's aspiration from the muscle may show gram-positive foci in pus. This is option number C is the correct answer. As the word suggests, pyomyositis, there's a pus collection in some muscle. Commonly, this may be involving the anterior aspect of the thigh or a gluteal region, and even sometimes in the psoas muscle may be involved. And most often organizes gram-positive foci as it written in option C. Staph aureus is the commonest thing. So antibiotic is the treatment of choice. Other than that, options are not correct. Glucocorticoid will not help, will cause more sepsis. It may be associated with connective tissue disorder, diabetes, and other immunocompromised status. But still, confirmation is by collecting pus or by imaging. Maybe MRI imaging of the muscle will be very helpful. Myositis antibody Jo1 is positive in patient who has an inflammatory myositis with ILD. This is a classical syndrome like antisynthetase syndrome. ILD with inflammatory muscle disease, nothing to do with pyomyositis. So this is also called tropical pyomyositis. So any of our panelists or a jury will like to add their experience with pyomyositis? till computer shows us the results of percentage distribution.
Gansham, very important again. We have to recognize pyomyositis where we should not use steroids immunomodulation.
Yes, sir. Steroid should be avoided, and antibiotic will be the thing. And if required, there's any pus collection, you should aspirate and see what organism gram stain, and maybe a culture will be a helpful thing. Anyone else want to add? And option C is majority of the students are correctly answered, 57%. So pyomyositis, they are able to make it out, and gram positive foci. That is important thing to do. So culture sensitivity will also be important. So drug of choice will be maybe a vancomycin or a penicillin group will be effective in these patients. We go ahead with question number 18 if computer allows us. So sorry. So we have winner for question number 17. I missed it. As Dr. Neha Thomas. She is from ESI Basai Darapur, Delhi. So we have a new winner for this time. Congratulations to Dr. Neha for correctly answering the question on pyomyositis. So we can go ahead with next question. Okay, so this is question number 18. It's a paraneoplastic cutaneous marker of internal malignancy with the hallmark finding being an abrupt eruption of multiple seborrheic keratosis. Which sign has been described? Is it trip palm sign? Is it generalized melanosis? Is it Lazar-Trillat sign, or is it Trozier sign? Your time starts now. The paraneoplastic syndrome, cutaneous syndrome. Thank you, Computer G. So time is over. So there are 4 options: tripe palm sign, generalized melanosis, Lazar-Trillat sign, and there was sudden onset of abrupt onset of these seborrheic papular lesion with hyperpigmentation in one of the malignancy as a paraneoplastic syndrome. Computer G, can we have the answer first? Okay, this is Lazar-Trillat sign. So in this, what happens that any patient who has an internal malignancy, like it may be a GI malignancy, it may be a pancreatic malignancy, it may be any genitourinary malignancy, which may present as a sudden appearance of these cutaneous lesions, and that may also be associated with acanthosis nigricans, like pigmentation also. So suddenly these erupts, and this may give you a clue that patient may have some internal malignancy. So imaging will help you, but more of a dermatologist will be the easy make these signs are more of a dermatologic finding. But once you see it, it will be very easy for you as it's a spotter for them. Other than that, generalized melanosis means generalized hyperpigmentation, which may occur in again pancreatic malignancy may present like this. And tripe palm sign is hyperkeratosis, so that there is a thickening of the palm of the patient, sudden development of this, which may also suggest that it's a paraneoplastic syndrome. And Trozier sign is left supraclavicular lymph node. This is not a cutaneous sign. It's more of a lymph node enlargement, especially left supraclavicular lymph node, which may be again enlarged due to maybe a GI malignancy, especially like gastric carcinoma, left lobe of the lung may be involved, or sometimes even testicular malignancy may present as a left supraclavicular lymph node enlargement, which is called Trozier sign. So if you can see here, 62% of the students have correctly answered this thing. Anyone wants to add or has seen this Trillat sign anytime during their practice? I have not seen. I have just the computer has given me this question. Seborrheic keratosis presentation, sudden eruptions in a paraneoplastic syndrome may present with the fever, weight loss, and sudden eruptions. So, Computer G, can we have the winner for question number 18? So it's Dr. Neha Thomas. She's from ESI Darapur, Basai Darapur. Congratulations to Dr. Neha for correctly answering and within 5 seconds. So we have given 20 seconds, so she has just taken 1/4 of the time. Computer G, can we have the next question? Okay, so this is question number 19. A 12-year-old boy developed a painful brownish raised lesion over the back of his leg associated with surrounding redness as shown in figure. You can see this figure here in the right side. 1 week after returning from a forest camp, so he's exposed him during a camp. The diagnosis was confirmed by a biopsy report showing microorganisms which when stained with Warthin-Starry stain. What is the most appropriate treatment? So some infection has occurred. Is it doxycycline? Is it amikacin? Is it metronidazole? Or is it ciprofloxacin? The time starts now. Thank you, Computer Ji. So the time is over. So there's a young boy who was going for hiking and he got bitten by some insect, or he had got some wound. So that is very, there's a red lesion which is raised and inflamed area. So you have a clue that something has happened here, and histopathology was done, and Martin's starry stain was used to stain this microorganism. So Computer Ji, can we have the correct answer for this infection? Okay, so doxycycline. So most likely it's an atypical infection. Very commonly used doxycycline for scrub typhus and all. But you all know scrub typhus, we don't use this Warthin-Starry stain. And this is more of a used stain in any spiropete infection. So gram-negative spiropete infection, which may also seen in a normal Giemsa stain, or sometime even with a dark stain, dark field microscopy. So this is commonly seen in this spiropetal infection, Borrelia burgdorferi, which is a Lyme disease. Very few cases have been reported from India, but very common in United States or North America. They may present as a PUO, they may present as a arthritis, they may present as a dementia, or they may present as a Alzheimer's disease also. So very myriad presentation. And if you can see here, correctly answered doxycycline, 85% of the students have correctly answered this thing. Anyone wants to add anything about Lyme's disease? A rare thing, but common in North America or other continent. Lyme's disease. So we have a winner here, Neha Tomar, not common in India, but Neha Tomar again, I think she has successfully answered this question. Third time she has answered this quiz, Norjol quiz. So we have completed the 19th question, and we can go ahead with the final question. Computer Ji. Okay, this is the 20th question. 54-year-old male is admitted with pneumonia and diarrhea. Sputum staining revealed numerous neutrophils without any organelles. Blood investigation revealed hyponatremia and deranged liver function test. Chest X-ray showed patchy alveolar infiltrate, which you can see on the right side, with round opacities as shown in the image below. So there's a bilateral pneumonia there. Image B, there was a no response seen with beta-lactam antibiotics. So he was treated with beta-lactam antibiotics, most probably ceftriaxone. What is the most likely cause of pneumonia? Is it pneumococcus, salmonella, legionella, or E. coli? Your time starts now. Thank you, Computer Ji. So we have completed 20th question. Okay, so Krishna, after 20th question, we can have two more questions. I think there was some problem with display of question. Computer Ji, Krishna, has everyone was able to see the question number 20th? Okay, if there is a requirement, we can go ahead with another question. So Legionella is the infection which may present as a bilateral pneumonia, and which is also called atypical pneumonia. And here they may not respond with the beta-lactam antibiotics. So you have to give cover with the any macrolide antibiotics or a newer fluoroquinolone, and they may present as a hyponatremia because they may be involved in SIADH. So there may be syndrome of inappropriate antidiuretic hormone release, which may cause hyponatremia in this patient, euvolemic hyponatremia, and sometimes they may also cause liver dysfunction. And to confirm this diagnosis, although sputum culture and sputum staining can help us, but you can even test urine for ELISA for Legionella, which is an easy to do test and with very good sensitivity and specificity. So Legionella is the correct answer, C option, and we can have the percentage distribution for the question number 20th. Any of the jury want to add anything about Legionella?
Sir, as you said, it is an atypical infection and it is actually found in fresh water normally. But if it is found in man-made water, that is the thing, that is the time when we are worried about, because then it leads to this type of infection and can spread like this.
So it can cause multi-system involvement, it may cause liver involvement as well as lung involvement. And majority of people have answered it correctly, Legionella. And can we have the results?
No, all have answered 100%.
100%. Okay, yeah.
Yeah.
But first is just sing.
Yeah.
Sorry? Fastest winner, first is the winner for this question. So
Yeah.
Dr. Seher Singh is the new winner. He's from Sri Balaji Action Medical Institute, Delhi, and he correctly answered within 5 seconds.
Okay.
So we have completed with 20 questions, and like to know from the organizer and computer G, should we run 1 or 2 questions more?
Yes,
because
sir.
one
Sure.
question was shown,
Yeah.
and
So,
there was some display error. with
Yeah.
that.
Yes.
As a
Sir, for the
jury,
back-end team.
Just as a jury, is it okay if I speak or after Krishna Kumar?
Yes, sir. You can speak, sir.
Yeah. See, question number 9 and question number 14, there have been some issues. So participants should get the benefit of answering 20 questions. So we will have to go with the 2 more questions, the reserve questions. Then, and this should be operated very correctly so that we give the participants the experience of 20 questions over. Others, please. Yeah.
Yes, sir. Any of the jury wants to add anything, because one of the question was shown, but someone must have answered question number 14 also. So that
No, sir.
winner will
14 was not displayed. From 13, it went to 15.
Yeah.
15. So we can display 14 again otherwise?
Yeah, no, sir. Again, 2 more questions will come now.
Okay, computer G, let us go with 2 more questions. Okay, so question number 21, which is the additional question. Which of the cancer does not have adequate evidence to link smoking as a causative agent? Is it bladder? Is it esophagus? Is it AML? Is it ovary? The time starts now. Most of them are caused by smoking, but except for one. Thank you, computer G. So time is over. You got 20 seconds to answer this, and this was the additional question. And this asks that all the cancer, most of the cancer has some relation with smoking, except one of them. And computer G will let us know what is the correct answer for question number 21. It's ovarian cancer. So it's ovarian cancer most commonly seen in females, and most of the, if you say Indian setting, very few females smoke. That is correct. But you all know that bladder cancer is one of the common factor is smoking, which can cause bladder cancer. Esophageal cancer is also very common in smoker. And while acute myelocytic leukemia has some association with smoking. So the correct answer was ovary, which has no evidence as such to link it with smoking. More of this cancer occurs more often due to some genetic defect. And any of our jury want to add anything on smoking related? I think Dr. So many carcinogens are there in smoking. And Dr. Any of jury want to add? Smoking related disease although COAD and lung cancer are more important for the smoking. And that pack here and smoking index we usually calculate for every smoker. But this is related to more of a cancer. So anyone? Okay, so I think most of the jury is also tired of such a long quiz. So we are at the back end of the quiz, and we can have percentage distribution for the answer. And 50% of the students have correctly answered question number 21. So ovarian cancer is not linked to smoking. So, but that will not benefit any males by not smoking because ovarian cancer is there in males. So we can have the answer. And for winner of question number 21, okay. Since Neha Thomas, she has permanently come back for last, I think 6-7 questions. She has correctly answered many questions. So she must be on the merit list for this North Zone to the Bangalore trip. She is almost there, I think. So I think this 22nd question will help her maybe to reach first or a second spot. Best wishes to Neha and everyone. This will be the last question for quiz unless we have a tie break. So if there's a tie break, we can go ahead with the 3 question or 1 question that we'll decide on.
We will decide. Let
go
us
ahead
see
with
this.
final question. Yeah. Computer Ji, we will go ahead with question number 22. So the false statement regarding fever is daily variation of oral temperature may be 0.5 to 1 degree centigrade. You have to say false statement. The morning temperature is about 37.2 degree Fahrenheit. The evening temperature is more than 37.7 degree Fahrenheit when you call it a fever. And the rectal temperature is 0.4 degree lower than oral temperature. Your time starts now. So which is the false statement? So thank you, Computer Ji. We are done with 20 questions. Who were the additional question because of some technical error, and we have come to the 20 question.
Pankaj, I have some clarification. Don't move the screen. See this B and C. It is 37.7 degree F. It is written. If I take it as Fahrenheit. Yeah, but it cannot be 37 degree Fahrenheit. Am I correct? So it cannot be. Yes, it is centigrade. The answer is given wrongly. Others, please comment on this response categories. Yeah, other internal medicine specialists to please answer. Yes, yeah. Please note. Yeah, this is error. 37 degree Fahrenheit is something totally different. I think let us repeat one more thing. Yeah, it is a wrong question.
Yes, sir. I think
Wrong.
This was degree centigrade,
wrong,
but
wrong.
wrongly written and wrongly
not properly validated.
So we will have one more question.
Yeah. Please. I am from community medicine also. Right. I am here to fine tune the operation.
Correctly, sir. You are quite correct.
Yeah.
Although people can interpret it, but still.
No. It is technically wrong.
Yes, sir. Computer Ji, can we have one question more from our question bank? So which of the following finding will confirm a diagnosis of severe preeclampsia? Is it serum creatinine of more than 0.8 milligram per deciliter? B is serum AST or serum SGOT level more than 140 milligram per deciliter? Is it 1+ proteinuria on dipstick, urine dipstick, or blood pressure of more than 158/96 mmHg? Your time starts now. It's severe preeclampsia. Thank you, Computer Ji. So we have this time, first time we are gone to 23 questions in a quiz, especially North Zone. And thank to Dr. Sudarshan, he has appropriately identified that there was an issue. So it is preeclampsia, more of a gynecological evaluation, but the reports which has been shown is more of a medicine. So Computer G, can we have the correct answer? So as per Computer G, this suggests that patient who has liver enzymes raised, especially more than 3 times. The normal values are around 35 to 40. So liver enzymes level more than 3 to 4 times will be labeled as a severe preeclampsia, although eclampsia is with seizure and all. So we all know that severe preeclampsia or a severe form will be having similar to like health syndrome, where there may be a signs of hemolysis, there may be a liver enzymes are raised, or there may be a platelets are reduced, or thrombocytopenia. So these will be the severe disease. So option B was correct. While serum creatinine 0.8 milligram per deciliter, which is normal value, will not label it as a severe, while 1+ proteinuria on a dipstick, which is a basic requirement for labeling as a preeclampsia, as well as BP for 158/96 doesn't match it to a severe category. So B was the correct answer. And any of our jury want to add any words to it, or we can go ahead with the percentage distribution for the correct answer. So Computer G, can we see the percentage distribution? So I think for 28% of the students have correctly answered, which is raised liver enzyme AST levels more than 140 milligram percentage. And this may lead to a fetal discourse if not treated properly or not handled properly.
Students have, I think, confused with the raised BP also, because it is a sign of eclampsia actually. But in preeclampsia also we have to look for raised BP, which is there. But severe form we have to look for this HELP syndrome type of picture.
Yeah, HELP mnemonic will help you in detecting the severe form.
Madam, actually, hypertensive pregnancy, preeclampsia, eclampsia, one of the causes, but the other causes of hypertensive pregnancy, so that cannot be more accurate. Elevated liver enzymes are more specific preeclampsia, severe preeclampsia, and proteinuria can be there in mild eclampsia also.
Yes,
so
sir.
elevated liver enzymes is more right answer. Yeah, I think answer is right.
Yes, sir. So can we have the winner for this question? Is Dr. Sahej. He's from Balaji Action Institute. Congratulations, Dr. Sahej. I think he has already answered few of previous questions also. So best of luck to all the participants and congratulations to all of you. Participation is important. Winning or losing or that doesn't matter. It's just a quiz, but I think we all learned a lot of infectious disease as well as a lot of about fever, thanks to our Fever Foundation for arranging this quiz. So we can compile the results. Request to Dr. Manjula and her team to just compile the result, and if we are able to make it out, who is the first winner and first runner-up. Any of the jury wants to add any comments, sir, till our team compile the result? If there's a tie break between first and second place, we will have to run a tie break again for 3 more questions. Okay, let's see.
Are 3 more questions there?
Computer G will help us from
okay. Good.
Sir, we have many tiebreaker questions.
Oh,
We can go long. Yes, sir.
Right. No, but dinner time.
Then we can have a dinner break in between,
Yes,
and then again we will start the quiz.
Yeah.
Right.
So to summarize,
yes, sir.
We have exposed the participants to 20 questions, but there were 2 questions. Question number 9, there was a wrong hurried display. It was withdrawn. Question number 14 was skipped. So 2 questions were removed. So additionally, another 2 questions had to be played. Question number 21 and 22 were used. 22 responses were wrong. Instead of centigrade, it was Fahrenheit in the fever measurement. So one more to question number 23 came in. So question 9 and 14 eliminated. Instead 21 and 23, they are the replacement. I have made a note.
Yes,
they are the replacement.
Thank you so much, sir.
Yeah. Only now I have to write down 2 names.
Yeah, so best wishes to all of you. Okay, so here's the answer sheet here. We have 1, 2, 3, 4, 5, 6. We have 6 winners as such for the quiz for very well participation. And the winner is Dr. Deepu Rajan. He's from Delhi. And as I told you, Dr. Neha did very well in the last part of the quiz. So congratulations to both Dr. Deepu Rajan and Dr. Neha Tomar. And both are from Basai Darapur, Delhi, for winning the North Zone quiz. And you are welcome to join the Fever conference in November in Bengaluru. And our Fever Foundation team will meet you and greet you and congratulate you. So congratulations from me and whole team of North Zone quiz team and jury and all. Well done. I think Deepu Rajan did very, very well, and as well as Neha and all other participants.
Yeah.
Congratulations to all the participants.
Yeah,
Congratulations.
Yeah. Well, without their participation, we could not have had the quiz.
So, Dr. Sudarshan sir, your final comments before.
Yeah, no, final comment. It is fine. It was really a very pleasurable experience, and for me, being from community medicine, of course, I did not know the answers of many of them, but I could fine tune, not with the knowledge of medicine. It was science only, general science, centigrade and Fahrenheit. I could do some error correction, and of course, as a jury, I have not only ensured fairness, I have also ensured that the fairness is seen. So I thank Dr. Manjula, Dr. Krishna Kumar, and Mr. Jairaj and others from Microlab, and my esteemed jury colleague, Dr. Narsimulu from Hyderabad, and of course our quiz master, Dr. Gansham Pangteji, and other experts, Dr. Subbalakshmi Margekar, Dr. Ramesh Agarwal, and Professor Jayant Kumar, and of course the computer team. Thank you very much for the invitation and for the
Thank you so
opportunity.
Much,
thank you. Thank you very
Thank
much.
you so much.
I am here till it is closed here. Thank you very much.
Dr. Narasimhan sir, yours.
And thank you. At the outset, I congratulate all the participants for their active participation. I feel all the participants are winners. Only first time to name check will to give a prize, but all need deserve to be given prize. And I thank my fellow colleague Sudarshan and Ghansam, excellent conductor Ramesh, Manjula, Jairas for excellent participation, flawless. And some of the mistakes what my colleague pointed out have been corrected, and it is a fair deal of conducting MCQ, and I compliment one and all for this.
Thank you so much, sir. Dr. Subbalakshmi and Dr. Ramesh Agarwal from you, sir. Comments.
Yeah. So it has been a very good learning platform, ma'am, for the last 3 days, what we have been observing. And today, with the expert guidance of Dr. Sudarshan and Dr. Narsimulu, we have seen that the competition has been really fair enough. And whatever mistakes were there on the screen were rightly pointed out. And the quiz has been so well organized and so well, the questions had been so well framed that I feel that both the general medicine, the autoimmunity, the infections, all have been covered well. And it was a learning experience both for the participants and the jury and the, of course, for all of us. So I wish all the participants a very good luck. Subbalakshmi, you please can have the final comments.
Yeah, so it was actually a wonderful quiz. We all have enjoyed actually the last 4 days. We are listening, learning, enjoying. And yes, every question was a learning. Every question was very well framed. And yes, students must have learned a lot. They have answered or not answered, that is something different. But learning is a process that must be continued. And I think this quiz will, the quiz has made sure that yes, we should be learning, and very well organized. Everything was very nice. So thank you very much. And congratulations to all the participants who have participated and done very well in the quiz.
Thank you so much. Professor Jain sir is also there. Sir, you would like to say, Panda sir, you would like to speak, sir? So, Ghanshyam sir, with your permission, can I close the today's this thing, sir?
Yes, ma'am. Please go ahead. I think we have a very entertaining and very academic session, and very well organized by Computerji. And in difficult times, and Computerji has helped us with this question bank. Thank you.
Yes. So once again, congratulations to Dr. Deepu Ranjan, Dr. Neha Thomas. Our Fever Foundation team will meet you and give you all the details, and you will be participating in the finals, which will be during FEFCON in November 2023. And I thank all the participants and congratulations to all of you for making this event very, very successful. Over to Mr. Jairat sir for final.
Yeah, Mr. Praveen will give the word of thanks.
Okay, Mr. Praveen, over to you.
Good evening to all the participants, and thank you for having participated. Without you participating, the Fever Quiz would not have been a successful event. And to make this a successful event, I thank Dr. Manjula ma'am and Dr. Krishna Kumar for having lined up such a wonderful, the flow of the event to planning and executing it to perfection. And the most important part of the Fever Foundation, or the pillars of the Fever Foundation, are our advisory board members. Dear sirs and ma'am, without you, things would not go smooth at all, things would not run at all. So I thank Dr. Sudarshan sir, Dr. Narsimlu Gumdala sir, Dr. Ramesh sir, Dr. Ganesh Gansham sir, and Shubhalakshmi ma'am, and Dr. Jayant Panda sir, and of course,
Anupam Prakash sir.
Yeah, Dr. Anupam Prakash, and of course our one of the pillars and the important people like Dr. Jagdish Chinnappa sir and Dr. Muruganathan sir, who have been with us throughout. And this quiz, I mean, last 4 days, I thank all the quiz masters who have kind of taken the quiz program to such a great level that definitely I feel that the bar has been raised this year. And the way Dr. Gansham Pantesa was like a marathon runner, he was taking up the the questions and answers, and the wealth, the knowledge wealth that was shared. It's amazing. We are blessed to be associated with all the Fever Foundation advisory board members. And sir, looking forward to have you all the winners along with the advisory board members in Bangalore, either through Zoom or person, depending upon the scenario or the situation. And thank you so much. And we shall do much better in the coming years. And of course, my mentor, my guide, Jairat sir, who has always been kind of pushing and making things happen. And I'm sure his guidance has definitely helped the Fever Quiz to achieve such great heights. Thank you to all, and good night.
Good night.
Good night. Thank you. Thank you, sir. Good night.
Thank you.
Good night, sir. Good night.
Namaste to all.
Good night, everybody.
Yeah.